Well, thank you for the kind introduction, Lucas. It is an honor for me to be here with you. It's a great joy to, and I have great appreciation for Dr. Gord's kind invitation and to be with you in Brazil, at least virtually and with my heart. And certainly I can tell you that Lucas, Dr. Browner Barcelos, they have done a terrific job creating a world-class hospital medicine group in Brazil, and it's very well recognized here in the United States. I want to share with you that you have outstanding leaders that we respect big time. So it is an honor to speak for you about perioperative anemia. This is one of the topics that is the most dear to my heart. And I just, as a brief introduction, why perioperative anemia? Why did I got interested in this? Because when I started working in the clinic 15 years ago, I was in the outpatient external consult service for perioperative patients. And I found that a lot of patients were coming with anemia. And I said, well, what are we going to do about it? Well, we don't have a protocol for that. And then I saw that a lot of patients were transfused indiscriminately. I said, how? So eventually, by being very vocal, I found that the Cleveland Clinic had some opportunities nationally for decreasing blood transfusion. And then I ended up leading, and now I lead the blood management group. So I have no conflict of interest to disclose. In an outline, we'll speak briefly about anemia physiology, then the evidence for transfusion medicine and the adverse effect of blood use, and then the protocol for anemia optimization, which we can apply in the perioperative setting. So as a context, we have this case of a patient that is going to have a colectomy. The patient hemoglobin is 8, and the anesthesiologist said, well, let's transfuse a unit of red blood cell to optimize oxygen delivery. The disagreement is based because the threshold for transfusion should be less than 7. We could optimize preload or oxygenation. So let's take a quick look to this. So this is perhaps the most important slide I present every single time I'm on service to both internal medicine or pediatric residents. So let's discuss about this. Oxygen delivery will be the product of your cardiac output times your arterial content of oxygen. The cardiac output is delivered by stroke volume and the heart rate. The stroke volume depends on your preload, afterload, and contractility. So modifying any of these things, giving the patient more fluid, letting the patient drink more water, making sure the patient does not have any malnutrition or malabsorption, improving the blood pressure control, optimizing electrolytes, thyroid function, and so forth, will optimize the stroke volume for this patient. And what's going to happen is also when we optimize heart rate, we are going to improve the cardiac output. So this determinant of the oxygen delivery can be modified without necessarily using blood products. Now, what about the arterial content of oxygen? Well, this will be determined by your saturation time. 1.34 is the amount of oxygen per gram of hemoglobin. So we could optimize oxygenation. I mean, we could improve VQ mismatch, find if there's a shunt, see if there's a diffusion problem, if there's hypoventilation, or if the patient is at a high altitude with low FiO2. So we can optimize this thing. Now, in regards with the hemoglobin, we are not going to be able to modify the genetic component. We cannot optimize the thalassemia or a sickle cell or a erythrocyte membrane problem like a spherocytosis. We can certainly optimize the hematinic nutritional support, iron, B12, folate, zinc, copper. We can also optimize hematopoiesis with erythropoietin. Now, when we look at this slide, basically what it shows you is the iron absorption in the duodenum by the divalent metal cotransporter, where iron in the ferric state by the duodenal cytochrome reductase is going to be reduced to iron in ferrous state. It goes to the cotransporter, and ferroportin will bring it down to the bloodstream, where hefestin will oxidize it back to ferric state, and it will be taken by the transferrin. 1 molecule of transferrin takes 2 molecules of iron, 1 molecule of ferritin takes 100 molecules of iron. But what's happened is that when we have an inflammatory state, the liver produces this protein called hepcidin. This hepcidin is going to block the absorption of iron from the duodenal cells, but also will impair the release from the reticuloendothelial system. So it's important to understand the role of inflammatory state in this patient, especially the surgical patient that have, for instance, inflammatory bowel disease that is not well controlled. Well, they're going to have anemia of chronic disease because of this problem. But on the other hand, when we use oral iron supplementation, it has been proven that if you give iron every single day or multiple times a day, paradoxically, you increase the production of hepcidin. This has led to changes in protocol to give the oral iron every other day, once a day. It's a big change in the paradigm. Now, when we speak about iron deficiency, we have the absolute iron deficiency when there is really no stores, ferritin is less than 100, transferrin saturation is less than 20%, reticulocyte hemoglobin content is less than 30%. But we also have, as I have told you already, when we have inflammation, we'll have functional iron deficiency because there's decreased turnover and decreased utilization. So this is going to lead to impairment in the end organ, in the muscle, all the organ that needs, and they have high mitochondrial function. Well, there will be decreased mitochondrial density. There will be decrease in the organization, the myofibrils, and it's going to create problems like muscle weakness, like cardiomyopathy, and so forth. So in this case, the disagreement will be that all of the above could be optimized rather than just transfusing the patient. Now, the surgery is postponed, hematinics are evaluated, and they are repeated parenterally with IV iron and IM-B12. When patient comes back, hemoglobin goes up to 11. So what are the expected outcomes? It is decreased blood transfusion, decreased morbidity, or decreased mortality. So we need to understand that patient population is going to be aging. Surgical patient population is aging. My surgical patient, most of them are above 70 years old. Here's the deal. The older the patient, the older we get, the more prevalence of anemia we have. So this is very important to acknowledge. So make sure that when you are seeing your patient, especially elderly patient, going to the geriatric clinic, address the anemia. Why are they anemic? Resolve that, fix that. Hopefully they will not need an operation. But the older we get, the likelihood of having a hip replacement and knee replacement is going to be higher. So let's stay as optimal as we can. Now, in this big trial of 227,000 patients, where 70,000 went with pre-op anemia to surgery, mortality and morbidity increased by 35 to 42% as compared with the patients that have no anemia. This retrospective study of 2,000 patients was one of the first studies in the decade of the 1990s. These were patients that refused transfusion, Jehovah's Witnesses. The patient whose hemoglobin was more than 12, they had a mortality of 1.3%. But the hemoglobin was less than 6, mortality rose to 33%. Now, when you see that the patient who have, they had no cardiovascular disease, well, then they were able to tolerate it. But the patient with cardiovascular disease, the mortality rose very prominently. So this started making an idea of, okay, what's going on here? So the patient with cardiovascular disease cannot tolerate that. And the inflection point was actually the point of 8. If you can see here, this is kind of where the graph actually goes upper. So this is why, based on this study, and I will talk about some randomized control trial, they kept up the hemoglobin of 8 to prevent adverse outcome in cardiovascular disease. Now, in this study, in patients that were undergoing coronary surgery, when you look at all the different cutoff values, when the hemoglobins are coming down below 11, they start having an increased risk in the incidence of adverse outcomes. So they have renal failure, they have stroke, they have AMI. So for now, these were in ICU patients with an Euro score more than 4, which basically meaning kind of like if you would look into more common tool that we use now, like an Apache 20 or so. Now, what happened in the patient that go to cardiac surgery? So the lower the hematocrit, the higher the mortality, the higher the risk of transfusion, of course, and the higher the risk of renal failure. So this is the Virginia Cardiac Service Quality Initiative. These are many thousands of patients that were being addressed. So it's clear that when anemia is not optimized, it's going to be a situation of adverse events for the patient. Now, what happens when we compare patients that have anemia versus no anemia, but between both groups, when they have no iron deficiency and they have iron deficiency? Iron deficiency, even in the non-anemic patients, iron deficiency confers a higher risk of mortality, serious adverse event, AKI, reoperation, wound infection, major adverse cardiac events, AMI, heart failure, and so forth. Now, from the MET study where we actually brought the data that we use all the time to estimate the patient's ability to do exercise. We looked at the lower the hemoglobin level will decrease the amount of oxygen uptake, the VO2, and will decrease the anaerobic threshold. So it's very important to aim to optimize this patient as much as we can before surgery, because surgery will be a very labile physiologic period, and we really want to maximize oxygen uptake, especially in target organ, as well as the anaerobic threshold, so to minimize complication. So in the Cleveland Clinic, we have this study that was done in post-op patients and finding out when they have non-cardiac surgery and if they develop anemia. So when the patient in the post-op day 3, when they have the hemoglobin go from 12 all the way down, when the core values are coming down between 10 and 9, especially 9 here is the inflection point, the risk of myocardial ischemia in non-cardiac surgery rises prominently. So for every gram per deciliter below 10 or 9, you increase by 30% your risk of means, by 34 your risk of means at 30 days. So what are we going to do with this? Well, this is something we are exploring now, because we have basically, we have to optimize those patients as much as we can perioperatively, rise the hemoglobin to 14, 15, 16 before surgery, and aim to find why they're anemic. So by the time they come to surgery, they do not drop the hemoglobin to this level, and we mitigate the risk of myocardial ischemia in non-ischemic surgery. Why does the preoperative anemia optimization often fail? Because we don't do it at long term, because we don't think about anemia, because we don't really optimize it. We want to give an infusion of iron a day before surgery. Well, that's not going to make a difference. We have to work many days. If we have this coronary patient who is having ongoing angina, well, they can start optimizing the oral iron, B12, folate, find out they have a myelodysplastic syndrome, optimize other things. So by the time they come to surgery, they are not exposed to this. Now, definitely you can always transfuse, but my conversation is to convince you otherwise to not use blood. Now, in this patient with coronary disease, when you have anemia, and this is a large cohort, 30,000 patients, 32,000 patients, all-cause mortality rises by almost 90%. Now, when this is in patients who have anemia, but when you optimize and normalize anemia, you decrease substantially, you decrease the risk of mortality. It's just borderline, not completely significant. And now there's some potential increase in the risk of bleeding. But nonetheless, there's a trend toward decreasing mortality when anemia is being normalized. Now, let's talk about some other surgical population. So this is when you compare the patient that go to hysterectomy and myomectomy, very common surgery in the United States, very common surgery in developing countries. You see that their anemia is going to increase the risk of death, complications, readmissions in any type of diagnosis, either fibroid or abnormal uterine bleeding or other type of diagnosis for which they get a hysterectomy. They will have high risk of transfusion, and they will also higher risk of readmission. So this is important to acknowledge that anemia in this population should be optimized well before they go to surgery. Now, this is a more recent study in Germany, and this is in subarachnoid hemorrhage patient. So the patients who have perioperanemia, they have an increased risk of transfusion 3 times intraarachnoid hemorrhage and 4 times an intracranial hemorrhage. But interestingly, they have 1.5 increased risk of death in subarachnoid hemorrhage and almost the same in intracranial hemorrhage. So one thing, I do not manage neurologic patient. In the Cleveland Clinic, the cardiac patients are managed by the cardiologist and the cardiac surgeon in the Heart and Vascular Institute. We do not see those patients. The neurologic patients are managed by the neurologist, the neurointensivist, the neurosurgeon in the Neurology Institute. We do not see those patients. Normal hospitalists do not see this. I want to lay that out. But one thing that we need to know from the blood management standpoint is that these patients with arachnoid hemorrhage or intracranial hemorrhage, they do not belong to the non-transfusional group. You may need to transfuse and keep them with hemoglobin of 10 or more, because if not, they are going to have high risk of mortality and worse outcome. The evidence in the neurologic literature is substantially high. This, I'm sharing this with you. This is a study from 2022. Just because there will be caveats where anemia maybe needs to be optimized in other things. And also subarachnoid hemorrhage will be an acute diagnosis. So you want to optimize them as much as you can and don't let them stay anemic. So what does the guidelines say? Well, the Society for Advancement of Patient Blood Management, they share, do not proceed with elective surgery until you diagnose the anemia properly. So this is very important, and we need to make sure that we need to make sure we optimize them. I always tell patients, elective surgery is elective. I mean, patients need to do a lot of things to optimize. They do prehabilitation. Prehabilitation is very important. They need to exercise before they go to surgery. Patients who are sedentary, they go to surgery, they will have worse outcome. You tell the patient, get up the chair, walk for 15 minutes a day, 20 minutes a day, 30 minutes a day, walk with the tiptoes, lift some weight, maybe cans, like a cans of beans or chickpeas or whatever, and do some weight lifting, do some exercise, take deep breath, pre-habilitation before surgery. Same thing, weight loss. If the patient have obesity, start cutting down on the carbs, increase the protein, and we eat more vegetable, more fruit, change that. The surgical period should be an opportunity to optimize a lot of things that have not been optimized. But definitely anemia is something that has to be optimized, because we don't want to reach this point where we have to transfuse the patient to avoid bad outcomes. So all of the above will be the outcomes. Patient will, by optimizing the anemia, we optimize the patient prognosis. So I have told you that anemia is bad. I mean, it increases morbidity and mortality. So what should we do? I mean, when we're going to transfuse patients, what should be the cutoff value? And we know that for subarachnoid hemorrhage, hemoglobin is 10, that's fine. We know that for sickle cell patient going to surgery, there's a study called TAPS, T-A-P-S, TAPS. TAPS study say hemoglobin should be 10 before surgery. But that's it. The rest of the patient, we were transfusing them on hemoglobin of 10 based on the studies done in dogs by Dr. Adams and Dr. Lundy in studies that were published in 1942. But the studies were never supported by evidence in humans. So this led to indiscriminate use of blood, and still nowadays in the United States, many doctors rebate me, well, I transfuse my patient with hemoglobin of 10 or a crit of 30. Well, that is not based on any evidence. So the NIH came up with this guideline saying that transfusing less than 7 probably will be the patient that will need transfusion. So this led to all these studies of normovolemic hemodilution, where the patient were exposed to phlebotomies to bleed them out from an hemoglobin of 14 or 12 all the way down to 8, and they saw that they were able to have an appropriate increase in the cardiac index, appropriate increase in the oxygen extraction. There were no significant changes in the EKG, and those patients were able to tolerate anemia appropriately. And when they did echocardiography, there were no significant increase in strain or mobility. Now, this led to studies in younger population to see the effect of anemia in the brain. And they found that the velocity for mathematical operation do decrease when the hemoglobin goes from 7 to 6, but when the patient gets transfused, the velocity for mathematical operation gets recovered. So they were able to demonstrate that hemoglobin of 7 in terms of central nervous system functioning was similar as a higher hemoglobin. Now, how does this compare to real patients? Are we comparing to the same? I mean, these are very standardized study patients. So this led to a variety of clinical trials. If you guys want to memorize one, memorize TRIC. TRIC is the trial you need to know, and read it and know it well. This in the ICU patient, and they compare transfusing the patient when the hemoglobin reaches less than 7 as compared to transfusing when the hemoglobin reached less than 9. When the patient were transfused with a higher trigger, they have actually worked out. Now, this was ICU patient, very sick patient. But we compare other population like septic shock, traumatic brain injury. The higher triggers had actually worse outcomes. We have the FOCUS trial. It's a perioperative trial in elderly orthopedic surgical patient going for hip or knee replacement with high cardiovascular risk. They had a cutoff value of 8 because of high cardiovascular risk, and they had the same outcome as higher threshold. We also have the studies in the patient that are bleeding, Villanueva and JRAT. They published these 2 fantastic studies. Villanueva found that the patient who were transfused to a higher trigger had worse outcomes as compared with the patient where you were waiting for an hemoglobin of 7. And the rest and the most recent studies have been focusing on cardiac surgery, have been focusing on acute AMI as well. And we have found with the reality trial with acute AMI that the cutoff value of 8 has the same outcome as a cutoff value of 10. So we have compelling evidence across the board that patient can tolerate anemia all the way down to 7 or 8 as a trigger for transfusion rather than liberally transfusing them. Now, when we look at this is the case of gynecological patient, this is the National Surgical Quality Improvement Database, 90,000 patients, where 1.6% of them had a transfusion perioperatively. Among all of these patients who were transfused, they have an increase, like almost 2-fold increasing with complication, almost 3-fold increase in thromboembolic event, and almost 7-fold increase in sepsis event. So what are the guidelines says? Well, they recommend to use hemoglobin for 7 for all hemodynamically stable patients, including critically ill, hemoglobin of 8 for orthosurgery, cardiac surgery, and all patients with cardiovascular disease. And there is no restriction of the blood cell age despite on storage life. We used to recommend to use fresh blood, not more than 5 days in the blood bank. After 5 days, throw them away. That led to a lot of waste. The evidence is compelling. If you use blood cells 2 weeks, all is okay to use. They don't really change that much the outcomes. So talking about the hysterectomy, we have a patient who required 3 units of blood already in the OR and the ICU. You are watching carefully, iron stores are low and hemoglobin is 7.1. So we say, well, this is moving target, let's transfuse, replete hematinics, evaluate for source control. The question here is based on the number of units that the patient has received. When we have a patient that's coming to our service, we see how many units of blood has that patient received so far. And we need to find out if this is Should we just stop transfusing? If the patient needs the blood, they need the blood, but when then we need to discuss with the patient about their prognosis. So this is in European ICUs. When we look at the mortality increase substantially when they transfuse more than 4 units. This is the National Surgical Quality Improvement Database of the American College of Surgeons. We also found that the more than 4 units increase the risk of infection, mortality, and length of stay. In a more recent study, this is the United States, the premier claim-based data, these are medical insurances. And they found it's just like 1,500,000 patients, a huge database. And they look at the patient who got transfused more than 4 units. They have a substantial increase in risk of stroke and AMI. So the magic number is 4 units. When the patient has received 4 units or more, let's stop there, aim not to transfuse them anymore, stop the bleeding, optimize the anemia, evaluate for hematinic deficiencies rather than just transfusing the patient. Now, the other risk with transfusion is not really viral infection. Most of the protocols nowadays of the blood bank really clean out viruses very well. They screen very well for this. Getting an infection, viral infection from blood transfusion is nowadays, 2022, is almost as getting hit by a lightning. It's rather more common to have transfusion-associated circulatory overload, where patients get congested just from the use of blood. I will tell you something. I don't think that any of my patients have a normal heart. Sorry, but they could have a normal ejection fraction. But I believe that 99% of my patients have heart failure with preserved ejection fraction, diastolic dysfunction, because of the diet, diabetes, hypertension, smoking, all the bad stuff happens in a lot of my patients. So the patient have very stiff ventricle. So even 1 unit of blood, even a little blood will let the patient not to tolerate that. The risk of them getting pulmonary edema is very high. We have been moving now toward using bedside echocardiography, where we actually use like the vascular expansion ultrasound called VEXUS, doing things to, and we only give some limited volume, and then we stop the volume. We don't do continuous IV fluids anymore. Why? Because of this. Well, this is something we have to be mindful when we transfuse the patient, listen to them, check at the pulse ox. If you don't look at the patient respiratory symptoms and get an X-ray if you need so. But it's important to rather optimize them with diuresis after transfusion rather than waiting for them. So repleting iron, B12, folate, zinc, copper will be better, and also stopping the bleeding rather than transfusion. So far, I have told you, anemia increases morbidity and mortality. When you transfuse, there's poor outcome associated with it. Therefore, we should aim for a non-transfusional effort. Okay. So, what are the protocols for perioperative anemia optimization? This is a cave in Iceland, and you can see the iron deposits here. We went there with my son in 2018 before the pandemic hit. So this algorithm is perhaps the single best algorithm for perioperative anemia evaluation. This is from Anesthesia and Analgesia, April 2020. So basically, the most common deficiency will be iron deficiency. If you want to memorize numbers, this is what you have to memorize. Transferrin saturation less than 20%, ferritin less than 100, or reticulocyte hemoglobin content less than 30%. So this is what we use to label iron deficiency, and then we repeat iron, IV iron. I mean, IV iron or oral iron. If we do this assessment many months earlier, we can start oral iron and assess response, make sure the patient doesn't have celiac disease or malabsorption. If iron is normal, then we can review for B12 and folate. If they're low, then we just replete it and aim to find what the cause for this. If they are normal, then we look for reticulocytosis. If it is low, then we look for anemia of chronic disease or chronic inflammation. What do the gastroenterologists recommend? They say do upper and lower endoscopy. If you have iron deficiency anemia, just scope above and below. Don't do a capsule. If you don't find bleeding, then just give iron and replete it. What they recommend to evaluate for it, evaluate for the endoscopy, especially in all postmenopausal women and all the males with iron deficiency anemia. Evaluate for it. Don't just give iron without evaluating. Now, if there's cost constraint, well, then you could potentially just replete it, but you don't want to miss a cancer or a lesion. Now, what happened with oral iron is that why do we advocate for IV iron in the perioperative period? Number one, because the perioperative period is a very short time frame for it. Number two, because oral iron can have many causes for not being well absorbed. When we have poor diet, well, we have the opportunity to change the diet. Patient can be anorectic with low protein, who have malabsorption because of the inflammation. A lot of patients take TOM, they take antacid, achlorhydria, they may have atrophic gastritis, they may have bacterial overgrowth. I mean, of these patients, they could have pernicious anemia. They could have also iron deficiency anemia. We need to think about those things. Bacterial overgrowth, especially patients who have a gastric bypass in the past, they have a blind loop. By patients who use antacids chronically, H. pylori infection, the chronic recurrent GI bleeding, patient with abnormal platelets, uremic patient who takes antiplatelet. When we cause the anemia, right, we get blood work and blood work, daily blood work, multiple tubes, we cause anemia. Patients have proteinuria, they throw the transferrin away, so they cannot have enough transferrin to bind the iron. The use of erythropoietin agent, celiac disease, the nutritional deficiency. So the Gansoni formula is what you can use to estimate iron deficiency. To be honest with you, on average, somebody whose hemoglobin is 10 to 11, they at least have a gram of iron deficiency. So we'll just replete a gram cold turkey. We don't do the Gansoni formula. We just replete a gram at a time. Now, when you have iron deficiency and anemia of chronic disease, this is a very nice study from New England Journal. I think this was in 2019. Okay, I have the reference in white here. Sorry about that. I could actually, let me. There we go. Sorry about that. I apologize for this. Okay, there you go. September 19. So you have the reference here. So this is pretty cool. This is a very good formula to know, to learn. This is very practical. So you look at the deficit in hemoglobin, multiply by the weight in pounds. So the weight in pounds is kilos times 2.2. For instance, 100 kilos patient with hemoglobin of 8. 100 kilos is 220 pounds. You multiply times 5. Why? Because you say normal hemoglobin is 13 minus 8 is 5. So this give us a deficit of 1 gram. So in anemia of chronic disease, you can just give 500 milligrams and you see what happens. So you can still replete iron, and this is something that you can use that can be very useful for your patient management. Now, use the formulation of iron you have available, okay? Just use any formulation is fine. There is no one better than another. We use ferrocit iron gluconate in the floors. We use iron sucrate outpatient. Some patient may be able to get carboxymaltose or derisomaltoside in the outpatient. That's prescribed by hematologist. I cannot prescribe it. Carboxymaltose, you can give up to 750 milligrams at a time, once a week. It causes a lot of hypophosphatemia. So what we do for the perioperative patient is we give the iron gluconate. We start a week or 10 days earlier. So we get the daily dose, so they can get 8 doses to give a full gram. Or we give iron sucrose every other day for 1 week, so they get at least 900 milligrams. You can use the Dectran. If you have the Dectran, you can use them. We don't prefer them because of the risk of anaphylaxis is way higher. But the good thing with the Dectran, you can give up to 1 gram dosing. Now, IV iron is safe. A serious hypersensitivity reaction happens in less than 1.7%, and the safest profile is with iron sucrose. This is a very nice study of 13,000 infusion where only 195 had a reaction to 1.4% of them. In 33 out of 33 with fish vein mild or moderate. So fish vein is when patient has some flushing or some myalgia, you can just re-challenge them. Mild will have mild erythema, but no hives, but they're localized cutaneous manifestation. Or moderate where they have some nausea, some cramping, maybe becoming a little bit hypotensive, or tachycardia, but they don't have airway problem. There's no bronchospasm, there's no laryngeal edema. In this patient, you could actually tolerate the recommencement. In 68 out of 69, they were actually able to challenge with a different formulation. The point is, IV iron is safe. You can just challenge your patient. Now, about the patient with dextran doses, this is the patient, the adverse event, a patient receiving pre-medication or at iron test dosing. And you can see that the rate of infusion reaction, I mean, when you are giving the test dosing, there is no significant changes. So, I mean, so you can probably just treat the patient. Now, the use of pre-medication, it probably helps the patient. Use of Tylenol, a different diphenhydramine may actually help to minimize the number of reactions. The point is, we do give a test dose. We give a small dosing. We give about, I think the test dose is 20 milligrams. If they tolerate, then we just give the whole gram of IV iron. Now, oral iron, I have told you, this is the evidence that we have of alternate dosing. This is in the Lancet. To alternate doses, so Monday, Wednesday, Friday, and next week, Monday, Wednesday, Friday. If the patient is very organized and they have a calendar, they can mark every other, they can Monday, Wednesday, Friday, Sunday, Tuesday, Thursday, Saturday, Monday. They can do that, that's fine. My patient not that organized, so I just say, okay, Monday, Wednesday, Friday, that's it. 3 times a week, once a day at nighttime, you take your iron, and it should be fine. About vitamin C, you can tell them it's okay to give vitamin C, 500 milligrams, 500 milligrams of vitamin C along with the iron. Now, this is pretty interesting study. This is, you have your patient, they are anemic, they are going to have surgery, and nobody optimized them. And they call you, and you have to optimize the patient. Well, there's nothing that I can do. Well, this is a quadruple therapy. This patient, on the day of surgery, they got 20 milligrams of IV iron, 4,000 units of EPO, 1 milligram of subcutaneous vitamin B12, and oral high dose of oral folic acid. They compared this with placebo. When you look the treatment across versus placebo post-op day 3 and 5, it's an increased hemoglobin count, increased retic count, increased reticulocyte, hemoglobin reticulocyte count. So among the patients who were treated, there's a response in hematopoiesis, and they decreased red blood transfusion about 1 unit as compared with nothing. So this is something to consider, that you can rapidly optimize your patient. Now, as I have told you already, there's evidence of hematopoiesis. Now, what about the patient who get IV iron and they get anemia, who get treated, they responded, hemoglobin rose to 13 or above. So the patient who responds, all this in white, you will see that in the number of units transfused, the number of units transfused will be very similar as compared with the patient with no anemia. So aim to correct the anemia in your patient before surgery, because the rate of transfusion will be very similar to the patient who has no anemia. Now, this is a nice summary of different populations, just to look at raw numbers. Colorectal surgery, you decrease transfusion by 52%, $3,000 per stay. Aorta surgery, cut transfusion rate by 30%, length of stay by almost 2 days, infection rate by 30%. In heart failure, the total cardiovascular hospitalization, heart failure hospitalization, cardiovascular death is decreased among the patients who get ferric carboxymaltose as compared with placebo. The same thing, the strain pattern among the patients who get placebo is higher than the patient who get iron. So this is cardiac MRI, and you look at the strain, how hard the muscle works to provide the contraction. You have a decrease in the strain pattern among the patient receiving IV iron. That's why in heart failure, IV iron becomes really important. Why? Because it increases mitochondrial density and myofibril rearrangement. Now, almost done. Not everything can be very clear. We had the PREVENT trial that was published a couple years ago, and basically they stated that this is looking at 500 patients in last decade, and looking at IV iron that was administered before elective major abdominal surgery. Now, this is not about this is just IV iron, not necessarily correcting anemia or anything, just IV iron given or not. So there's just a lot of caveats to look into this trial. But nonetheless, among the patients who got IV iron versus placebo, there was no changes in blood transfusion or death or transfusion episode. Nonetheless, IV iron was associated with decreasing the rate of readmission, about 40 to 45%. Also a decrease in the discharge at 6 months. So the readmission after 6 months is also decreased by 22 to almost 40%. So there is some effect of IV iron. Now, again, this is IV iron administration. You need not just to give IV iron. You need to make sure there is an improvement in the hemoglobin levels. You're just giving the IV iron by itself, when we do not recheck iron stores, we do not recheck a CBC, doesn't help the patient. So it should come up with a reassessment of the patient blood count. So this is what just recently published. So this is a study in about 1,400 patients. When we look at the use of erythropoietin and the single dose of EPO prior to surgery, and there's a trend, I mean, it's non-significant, but there's a trend toward decreasing the risk of transfusion and perhaps considering these. And there's also, based on the hemoglobin level, also a trend in improving hemoglobin. Now, when we look at the Cochrane review that was done in 2020, they found that the use of erythropoietin prior to surgery, there's a decrease of about 45% of post-op transfusion. Nonetheless, the data is not, there's a tendency for this, there's still a need for a more randomized control trial. Now, this study that was done in cardiac surgical patients, and when we look at the patient who have preoperative erythropoietin, and there's a overall actually 51% decrease in the rate of transfusion as compared with the patient who get intraoperative erythropoietin, where there is not significant. So when you use pre-op EPO in cardiac surgery, you actually have a decrease in the rate of transfusion. So there's more compelling data. This is 2022 data as demonstrating that erythropoietin may be an adjunct that we can use. We've been very scared of using EPO. Normally, I do not prescribe EPO often because of the rate of DVT, deep venous thrombosis, hypertension, and other complications. So when we put all things together, when we treat, we manage anemia, well, we want to improve the physiological adaptation to maintain oxygen homeostasis, I mean, consumption and diffusion and delivery, and minimize the hypoxemia that is induced by anemia. Also decrease the rate of transfusion. So when we do multimodal patient blood management, IV iron, oral B12, oral folate, EPO, we minimize transfusion, we do the scopes, we provide IV iron, we do the combination of the treatment. All of these tend to decrease erythrocyte transfusion. Multimodal blood management is more effective than just IV iron. EPO is more effective than just IV iron alone, but EPO is something we don't use that often. But we don't have clear data. When we improve now, I have told you at the very beginning that anemia is associated with worse outcomes. But nonetheless, in terms of organ injury and mortality, it's still not clear whether just doing all this optimization will impact here. Nonetheless, blood utilization caused bad outcomes, so I presume that there will be an improvement in this domain. So what is what I do? I cannot fix the genetic issues. I cannot fix the sickle cell, I cannot fix the thalassemia. I cannot fix the spherocytosis. That I cannot do. I can replete imatinib. I can assess for them. I can replete imatinics are the nutrition substrate to optimize hematopoiesis. I can assess for iron, B12, zinc, copper, folate. We don't necessarily check for folic acid. We can just replete it, but we can optimize that. I can evaluate for malabsorption. I can look for celiac disease, pernicious anemia, small intestine, bacterial overgrowth, stop the PPI use. I can evaluate for chronic blood loss. I can do source control and definitely consider erythropoietin. So there are things that can be done that should be done way earlier rather than later. If we cannot change our minds, we cannot change anything. With this, I conclude my presentation. This is my email. This is my Twitter account. I'm a very heavy met Twitter. So please feel free to reach out to me.